Assalamualaikum and good day to respected panel. My name is Faiz Beji Samsudin, and today I will present my research proposal entitled The Relationship Between Kinesophobia and Return to Sport Readiness Among Patients with Lower Limb Injury. This study focuses on psychological aspects of the rehabilitation among individuals with lower limb injuries, especially with fear of movement and their readiness to return to sport. As for the research background, lower limb injury are common among athletes and also physical activity individuals. This injury may involve the hip, knee, ankle, and also Achilles tendon or any lower limb muscle. And the main issue here is that how the lower limb injury do not only cause a physical damage, but they also disrupt sport participation of an individual. The patient with lower limb injury may experience reduced quality of life, delay rehabilitation progress, and also fear of re-injury. One key psychological barrier is kinesophobia, which means fear of movement or fear of re-injury occur. And another issue of the measurement gap. Much of existing evidence of psychological readiness is focused on ACL reconstruction population. However, lower limb injury is more than that, broader than ACL injury alone. Therefore, this study adds value by examining how fear-related movement beliefs are associated with return to sport readiness. The first problem is the inadequacy of physical clearance alone in rehabilitation. Patients may consider physically ready based on strength, range of motion, or functional tests. However, this does not mean they are psychologically ready. The second problem is that the evidence base is skewed, which is mean most of the strongest research linking fear and return to sport readiness has focused on ACL reconstruction, just like what I talked on the research background. The third problem is the neglect of non-ACL injury, just like what we talked on the second problem. And the final issue is the lack of control profiling. The first objective of this study is to assess the level of kinesophobia and return to sport readiness among patients with lower limb injury. The related hypothesis is that the patient with lower limb injury will demonstrate measurable level of kinesophobia and also return to sport readiness. Moving into the second objective, which is to determine the relationship between kinesophobia and return to sport readiness. And the hypothesis is state that there will be a significant negative relationship between these two variables. By how? This means that when fear of movement is higher, the return of sport readiness is lower. The third objective is to evaluate whether the kinesophobia significantly predict return to sport readiness after controlling the age, sex, injury type, pain level, and time since injury. Moving on the first study, Cimenti and colleagues found that the elevated kinesophobia was associated with reduced recovery from lower extremity musculoskeletal injury. On the second study, Amber Gauka and his colleagues conduct a systematic review on kinesophobia in injured athletes. Their review showed that kinesophobia is associated with for a physical and mental outcome. However, the evidence is still uneven and tend to focus more on specific lower extremity injury. Meanwhile, Luzhnitsky and colleagues examined the IPRRS, which is the questionnaire that will be used in this study, which is how their findings support the use of IPRRS as a measure of psychological readiness among physically activity injured individuals. Fourth, Smiley and colleagues review lower extremity return to sport testing. Their review showed that there is no universal functional clearance battery for all lower limb injury. This support that the ideal return to sport assessment must be broadened and should include the psychological measure. Finally, Liu and No reviewed psychological readiness scale and found that self-reported readiness tool can predict return to sport outcome. However, many studies still rely heavily on self-report tools, and the interaction between fear and readiness need further investigation. The framework begins when the patient interprets pain or re-injury risk as threatening. For example, when the patient thinks about running, jumping, landing or cutting, they may perceive these movements are unsafe. This creates a threat appraisal where the movement is mentally judged as dangerous. When movement is seen as unsafe, avoidance behavior may occur which lead the patient avoid the exercise, and this will reduce the sport-specific movement or limit the exposure of the athlete to a situation that actually require confidence in the injured limb, such as in real-life competition games or any situation that will have a stress on them. Over time, this avoidance can reinforce the perception that movement is dangerous in their head. In this study, the TSK11 is used to measure fear-related movement belief, which is kinesophobia. Meanwhile, the IPRRS is used to measure perceived psychological readiness return to sport. Therefore, these frameworks support the idea that higher kinesophobia may associate with lower return to sport readiness. Based on the G-power output, the minimum required sample for this study is 71 participants. However, to reduce the risk of data loss or incomplete response or attrition, a 20% adjustment will be added. Therefore, the final target sample size is 18,600 participants, which is we will target more than that. This sample size is intended to provide a sufficient statistical power for examine whether kinesophobia predict the return to sport readiness. This slide will present the inclusion and the exclusion criteria of the participant will participate in this study. For the inclusion criteria, the participant must be more than 18 years old and above. They must have verified medical diagnosis of lower limb injury, also have participated in sport or any structured physical activity before the injury. Another important criteria is that participants must have intention to return to active physical activity. This is important because the study focuses on return to sport readiness. So, the participant must be relevant to the outcome. They must also be able to understand the study information and provide voluntary informed consent. Moving into the exclusion criteria, individual will be below than 8 years old not be included. Participants who also refuse to consent of submit incomplete questionnaire will be also excluded. Thus, with neurological disorder, cognitive impairment, isolated upper limb or spinal injury, or non-musculoskeletal condition will also be excluded in this study. In addition, individuals with medical condition that permanently prevent them to return to sport will also be excluded because their return to sport readiness may be affected by factors outside the focus on this study. These criteria that have been stated will ensure that participants are suitable and relevant to the research objective. Moving into the first, which is the Tampa scale for kinesiophobia, which is TSK11. Moving into the second instrument, which is the injury psychological readiness return to sport scale, which is IPRRS. As for the third instrument, the demography, this section will collect important background information, will be including the age, sex, gender, sport background, injury type, anatomical injury site, pain level, time since injury, rehabilitation pace, previous injury history, surgical history, and current return to sport status. Together, this instrument allows the study to measure the main psychological variables and also control for important demographic and clinical factors. Moving into the next slide, this slide will explain the four phases of the research procedure. Moving into the first phase, which is the ethical and institutional clearance. The second phase is a purposive requirement and consent. As for the third phase, is a cross-sectional data collection, which the data will be collected at one point in time using the secure online form. Participants will be completed the demographic and clinical survey, the TSK11 and the IPRRS. Moving into the phase 4, which is the data verification and cleaning. Before the statistical analysis, the respondent will be screened for concern, completeness and duplicate, eligibility and outliers. This step is important to improve the quality and reliability of the data set. This slide will summarize the statistical analysis plan. All analyses will be conducted using Jamovi. The significance level will be set at P less than 0.5 for inferential analysis. For the demography, baseline categorical variables such as the sex, injury types, and sport background will be reported using frequency and percentage. Continued variables such as the age, pain level, and times since injury will be reported using mean and standard deviation. For objective 1, descriptive statistics will be used to assess the level of kinesiophobia and the return to sport readiness. For the objective number 2, Pearson correlation will be used to examine the relationship between TSK11 and IPRRS score if the assumptions are mean. If normality or linearity assumptions are violated, Spearman rank order correlation will be used instead. For the objective number 3, hierarchically multiplied linear regression will be used. In block 1, the control variable will be entered including age, sex, injury type, pain level, and time cease injury. And in Block 2, the TSK score will be added. The main clinical issue is that unidentified kinesiophobia may delay functional progression and reduce exercise participation. This can lead to restrict return to sport outcome. For example, a patient may have a decreased strength or range of motion, but may still hesitate to run, jump, land or return to competition because of fear and uncertainty to move in normal way. The integrated solution process in this study is to use the TSK11 and IPRRS as a complementary tools. The TSK11 help to identify the fear-based barriers, while the IPRRS capture the confidence-based readiness. To conclude, this research proposal focuses on the relationship between kinesiophobia and return to sport readiness among patients with lower limb injury. This study aims to assess the level of kinesiophobia and return to sport readiness, examine the relationship between these variables, and determine whether the kinesiophobia predict return to sport readiness after controlling for selected demography and clinical factors. That concludes my research proposal presentation. Thank you for your attention for the respected panel, and I welcome any question and comment or suggestion from the respected panel. Thank you.